Sorry, I'm just moving something off my screen. Good morning, everyone. And for those of you who aren't in Western Australia, good afternoon. And I also recognise that many of us are now working in a lockdown or indeed quarantine environment. So we're just upskilling again about increased virtual. But thank you all for making the time to be available today. This is a short session, but what I'd like to do is just do a very quick introduction and then we'll move into the session. Firstly, I'd like to acknowledge the traditional owners of the land that we are all meeting on here today and the varying locations across Australia, but pay our respect to the traditional owners and elders of this significant country, and also recognising the risks associated for many of our vulnerable colleagues and communities during this time. But we recognise the significant cultural heritage and value of the First Nations people to our broader community. Now, this piece of work has been a little bit long in the gestation, but is really important as a tool, I guess I say that, as a tool for clinicians and service providers to enable them to look at the suite of options that are available in supporting vulnerable members of the community and people who are seeking care. Now, just very quickly, I'll move through just a bit of background, which might explain why is low intensity service provision really important in the mental health environment. And the first slide that we'll come to is just an overview of the expenditure of better access and the PHN contribution, for want of a better term, to that environment. Now, look, we're just having a little trouble here getting this picture, this screen present, but it's coming. Here it is. Thank you very much, Peter. And you'll see here that MBS rebates are the majority of expenditure in primary mental health care across Australia. And the dark blue box on each of those states shows the PHN flexible funding that goes towards mental health service provision. The next slide is quite important. And from my perspective, the setting of the scene here that's important is not only the growth that's been in better access over the duration of the last 15 years or thereabouts, but also you can see from the mental health service use and disadvantage data there, the skew, for want of a better term, about who is accessing services. So, for example, use of services per 100 people, it's a very different skew to those who are poorer. So people who are more advantaged, for want of a better term, are able to access better access, for example, much more easily than people who live in disadvantaged communities. And you can all make sense of that. The next slide just shows some of the more recent investments and developments in mental health across Australia, and Headspace being part of this lower intensity environment. Similarly, Head to Health and the Head to Health hubs, which were developed in Victoria as part of the response to COVID. But the new and emerging initial assessment and referral process is a means to ensure that people are accessing the right care that they require, the right level of care, and the situation of that care. Finally, you can see from the next slide just an overview of the low intensity service provision, where that occurs across our environment here in WA, and you can see the access in the lower half of WA. But conversely, I think the important piece to recognise here is low intensity is effectively, on one hand, an earlier intervention to ensure that in a stepped care environment, people are better equipped to also manage their own mental health and well-being, not necessarily always reliant on a better access type service or a therapeutic, I say that word loosely, intervention. So it's important for us to help equip clinicians and providers to be able to look at and consider how low intensity can be better supported in their clinical environments. So on that note, I'm going to hand over now to, and you'll be able to get a copy, hand over to Danny just to set the scene a little bit further. Danny, you're on mute.
I did my first, I gave a presentation 2 weeks ago on a Friday, and it was my first in-person presentation for 16 months. And I think I didn't have to press a mute button before I spoke. And I think I've had one in-person presentation, and it's impressed itself on my brain. So I apologize. I think it's important to provide some context, and thank you, Learne, provide good national context around low intensity, but also from a PHN perspective, for people, for an understanding of what PHNs are for. And in our guidance, we're for increasing the efficiency and effectiveness of medical services, particularly at those at risk of poor outcomes. Can I have the next slide, please? And when you look in medical care, primary care, we can't take a condition-specific approach. I mean, when this multimorbidity is common, and it's common amongst people who go into primary care. We have individuals who are seen by general practice who have often this triad of a cardiometabolic disease, some disease associated with pain, and not chronic pain, but a painful condition, and often accompanied by depression. Over 30 to 40% of people with a pain condition and a cardiometabolic disease have a depressive disorder of a mild or moderate form, predominantly mild. Can you just press the button again, please? And here, the interventions are both limited and effective. So you can use medication, but medication adds complexity and it's not always necessary. And the other intervention, of course, is psychotherapies. And the current offering of psychotherapy is better access. But we know that better access provision is not universally available, although the better access is designed around universality. Can I have the next slide, please? And for PHNs, we're targeted at individuals with or at risk of developing mild to moderate mental illness, who can be appropriately managed in primary care and who cannot equitably access MBS treatments. So we're in the mild to moderate part of the spectrum. Next slide, please. And that's a very big group. This is Australian data. There is 2.3 million people with estimated to have a mild mental disorder, 1.2 million people estimated to have a moderate disorder. Next slide, please. And so what is it that we as a PHN support? We support treatments. We support two forms of psychological treatments: low intensity psychological interventions and standard psychological therapies. And both of these are structured. They should be structured. Next slide, please. And just press the button again once more. And where low intensity sits in the step care spectrum is at level 2. And it's low intensity and it's a high volume service. We've got a large population, and it's the most undifferentiated part of the health primary care system in mental health. Next slide, please. And this was talked about in the Productivity Commission's report, and often the word gap and mental health provision go together in Australia. And when we think about gaps, well, of course, lots of people talk about the missing middle. And the Productivity Commission did address some comments around the missing middle, but they also addressed the other gap, the low intensity gap. And they said it was large, and they said it was consequential at a population level. And they identified the two groups of people, the half a million people in the population who would benefit from low intensity care, but are not accessing any care whatsoever. And then quite a number of those would be people with multimorbidity. And the up to 2 million people who have been treated with medication, and we're very, very high users of antidepressant medication in Australia, and individual therapy, who could have their treatment needs met equally well through services that offer low intensity treatment in terms of their time, their cost, and the treatment and adverse effects. So the gap is, as they said, large and consequential. Next slide, please. And so we've developed a manual, and I have to, and Peter, who's coming after me, will talk about the development of the manual. But in that development, in the thinking around that, I think there were three themes that pushed us forward. The country WA mental health portal providers, the set of people who provide services in the country, were asking, well, we'll be asked, you're commissioning this, but we need more detail about what it is. And we committed to develop a manual to support that. And then a number of Metro Commission services also said, in fact, for example, GP Down South, who does both the country, said, well, we need the same thing in Metro. And then from GPs, we had, well, we don't know what this is. We know that we need something more, but we also want to be confident that what is being offered works. Not that it's just seeing a person for a conversation, but it has a therapeutic or an intentional process associated with it. And we committed to this, and we're very lucky in Western Australia, in Australia in particular, we're in Western Australia, because it's one thing to commit to something, but it's also important that you have the expertise on hand. And when you look around the country, Western Australia is particularly well equipped through the work Peter, who will come after me, will talk about at Curtin University, and through the work of the Centre for Clinical Interventions. And so we went to them and said, how can we do this together? How can we create a manual that can be used practically by services and clinicians to construct their own approaches in a relatively standardized way to address this very consequential gap in our services and enable us to commission to optimize care for people, particularly with multimorbidity. So Peter's going to talk next about the actual manual and the approach, and following Peter, we'll take some questions. So Peter.
Thank you very much, Danny. Hopefully you can all see my screen now. Hopefully I can move through my slides. I would also like to acknowledge the traditional owners of all the lands on which we're meeting, but particularly the Whadjuk people of the Noongar Nation, which is the lands that I have the privilege to live on and work on. I recognise and respect their cultural heritage, beliefs and relationships with the land, and pay my respects to the elders past, present and emerging. I would also like to acknowledge the co-authors of the manual. I was very fortunate to put together a crack team. Ebony was completing a clinical psychology master's and PhD, but the great thing about having Ebony on board is that she was actually a 4+2 psychologist working in rural Western Australia after doing her 4-year undergraduate degree. So she was working in this space, and so she was really quite well attuned to the issues that country practitioners who may be new to delivering low intensity services may benefit from, what sort of guidance they may benefit from. Caitlin Piercy is a clinical psychologist in private practice, so that's again another angle that we're able to bring in. And Bruce Campbell, who's the director of the Centre for Clinical Interventions, was kind enough to come on board, and I just want to acknowledge that CCI shared a lot of their materials into this manual also. And also Danny's input in guiding the priorities and the structure and the need. So what is low intensity? There's already been some discussion today, but what binds them together is that these interventions radically reduce the amount of specialist therapist input needed to treat patients. We know specialists are in very short supply, and significantly increase access to effective services. And I should underline effective services, because we want to ensure that low intensity interventions are effective for our clients. As a clinician, that's certainly my priority. So low intensity doesn't mean less effective. It means at least as effective as any other treatment that would be delivered to address the client's needs. And they tend to be cost effective as well. So the whole grail really with low intensity interventions, as I mentioned before, is to maintain or even improve outcomes with maximum efficiency. So the least restrictive treatment from the client's perspective, and also least costly from the health services perspective, but also delivering treatment to the most people possible within the available resources. And I think it's best considered a continuum rather than a dichotomy, a range of dimensions that we can shift along to make an intervention more or less intensive. So low intensity interventions, as was mentioned before, are offered earlier in stepped care, which aim to match services with the client's needs, no more and certainly no less. So these are some of those factors that can influence the intensity of an intervention. Obviously, the level of support. A treatment that's relatively unguided or self-help is going to be lower intensity than one that's guided. One that's delivered at home or in the community or in a non-government organisation is likely to be less intensive than one in primary care or outpatient or inpatient. But again, these are continua, not dichotomies. The format delivered in group, for example, may be less intense and more cost-effective than individually. Delivered via internet or phone compared to face-to-face, one that's briefer rather than longer, one that's delivered by a generalist rather than specialist, delivering an intervention at a population level versus an individual. And as Daniel was saying, there's a high level of comorbidity in clinical practice. We're all aware of that. It's far more common that our clients are going to come in with more than one problem at a time. So low intensity intervention would aim to address multiple problems rather than focusing on one. And cost generally tends to be less per patient or per client than higher intensity interventions. So we can pull any of these levers to make an intervention more or less intensive based on the available resources and based on client need. In terms of the features of LIPIs, they tend to be targeted, so addressing lower intensity needs, less acute needs, certainly trying to prevent a worsening of symptoms or the need for more acute services. They tend to be more time limited, so briefer and more structured, highly efficient and cost effective, definitely evidence-based, so they're shown to be effective by research. Highly accessible, easily and rapidly accessed when required. They're flexible from the client's perspective in terms of meeting them where they need to be met, but also from the clinician's perspective, so that they're delivered when, where, and how they're required to be received. Can be provided by a broad workforce, so suitably qualified generalist clinicians can administer them with fidelity and effectively. They are regionally focused, so they can address the needs of the local area. They're recovery focused, so they promote recovery and match, as I mentioned before, match the client's needs. Designed to promote coping, develop confidence in self-management, and as I've mentioned now several times, effective, that is critical. So we're not wanting to deliver less effective interventions just because they're lower intensity. So in terms of the guide itself, we structured it with really one of the guiding principles. We wanted to be comprehensive to provide clinicians with guidance from the initial assessment all the way through to treatment development and implementation and evaluation, but also just providing the information that really was needed. So we structured it around 4 chapters. Firstly, the why, what, when, the types of LIPIs and for whom, some general background information. And then chapter 2 is guided around the assessment. So how can we rapidly, yet comprehensively, assess a client and create a problem formulation that would then guide the treatment to ensure that it's effective. Chapter 3 is around delivering LIPIs individually, but also recognise that a lot of services may be seeing similar clinical problems across multiple clients, in which case it's going to be more effective or certainly more efficient to deliver the intervention in groups. And also within a group, you get the benefit of the group dynamic as well, which can really help to support people's recovery. The appendices are designed to be really useful resources for clinicians, a whole range of information about outcome monitoring measures, so clinicians can identify what clinical problem they need to assess, and they can go straight to a measure that's freely available, that's open access, they don't need to pay for, and that's brief, and it's feasible within clinical practice to use. We provide some guidance about how to link clinical problems to symptoms and treatment options and resources, provide a simple formulation, quick guide and a template to guide people's assessments within a LIPI context, and also a group LIPI session plan design. So what I'm going to do is just open up the actual manual itself and just give people a very quick guide of the manual. The cover page really just outlines what I've just described. So the first chapter is all about what LIPIs are. The second chapter, as I mentioned, is about assessment problem formulation. So it also talks through the assessment process, how to rapidly build rapport, how to foster active participation, because although low intensity interventions are low intensity from the clinicians and health services perspective, it's certainly not low intensity from the client's perspective. It requires a lot of effort and engagement. So we need to, from the outset, be able to foster that engagement. So we spend some time talking about how to do that over different modalities, over phone or video conferencing, how to describe the rationale for a LIPI as well with clients, how to adapt to time limits, how to identify outcome measures that may be useful, how to conduct rapid risk assessments as well, and to focus then in on the problem statement. What is the LIPI needing to focus on from the client's perspective? How to develop a simple case formulation that will guide your intervention. We've used the hot cross bun model, which most people will be familiar with, and we've included a range of guidance and some dialogue as well about how to assess the content so that you can complete your formulation. We've included a range of examples for a range of different clinical problems as well, just to give clinicians some guidance about what this might look like once it's completed for a client with different presentations, and some dialogue about listening that information. So one for depression, one for social anxiety, panic disorder, and generalized anxiety disorder. So there's a diversity of presentations there. Then developing your LIPI, a whole range of factors to consider, some flowcharts about making decisions about who's appropriate, who's not, and how to move forward. So decision tree there. Again, more examples about outcome monitoring session by session so that you can ensure your intervention is effective. And I'll just jump to one of the appendices here as well, just to illustrate that we've provided a table here that links the various clinical problems to symptoms, to treatment options, and some online resources that can help structure that particular technique to address that clinical problem. So we've done that for behaviours, particular thoughts, emotion management as well, body sensations associated with the problems. The formulation here. Here's a template that people can complete with their client that identifies the clinical problem, the formulation, which LIPI modality might be most appropriate, how to plan their intervention, structure their sessions, what outcomes need to be monitored and how frequently they'll be monitored, and also from the outset deciding what a successful outcome would be. And we've here's just a pro forma to guide that assessment, and also similar form to guide the development of the group LIPI as well, session by session. So just coming back here to individual, I'll finish up in a minute. To open up for questions, so setting goals, motivational interviewing to really engage clients in the process of change. More case examples related to the LIPI itself. More information to guide the formulation. And here's a completed LIPI formulation and treatment plan, again, just to guide clinicians about what that might look like when you're working with a client with a LIPI. You've got a full treatment plan here that's structured, you know, they're evidence-based techniques that you're integrating and should be effective for the clinical problem. We've got our outcome monitoring sorted. And in groups, just to finish off, we've talked about when a group LIPI might be appropriate, how you'd select clients and set up the group, how you go about setting up the group, group sizes. So a whole range of guidance there. Again, there's a treatment plan for your group LIPI, the process of conducting the LIPI, and also I just wanted to get to the outcome monitoring. So you might have a range of different clients here. They all follow a different trajectory. Hopefully most of them are improving as they are on this graph. But also we talk about how to manage when clients haven't benefited from the LIPI either, how you might respond to that. But without this data, without the monitoring, then you won't know who's responded, who hasn't, and steps forward. So that's really all I wanted to talk people through. Oh, there's just the table with all the outcome measures for different clinical problems and where the links are, where you can actually access those. So really the manual is designed to be a really comprehensive one-stop shop, if you like, for developing and delivering a LIPI.
Thank you, Peter. I know that you've rushed through that, but it's an invaluable resource for clinicians and really well set out, I have to say, very clear. So thank you to you and the broader team. We have probably 1 or 2 minutes to take some questions, and if there are some that come in, we'll address those. I just thought I'd mention a very important statement that you made, Peter, which was from a client's or perspective or a patient's perspective, just because it's low intensity doesn't mean it's not going to have efficacy, and it's an important method of care and support. And I think sometimes when people see low intensity, it's a bit like they won't get enough of what they need, or, you know, it won't be getting to the base of the problem for the individual. So I think you've dispelled that mythology that low intensity is a really important element of stepped care. And the other piece being that when we look across the data that is provided to us by the service providers, on average, people really only have 4, maybe 5 interactions and a K10 is used, which starts to demonstrate that, in fact, that probably is meeting the need of the person who's seeking service. And it doesn't mean it's less efficacious or so forth. So thank you. That was really helpful, and it was a really good presentation. Now, do we have any questions? Are there any questions coming in on the chat or online? And if not, we might give you 30 seconds back, noting that we are going to provide both printed copies, but also it will be available online via WAPHA. So stay tuned for that. But it is a great resource, I have to say, and I really appreciate the efforts that have gone in by not only the WAPHA staff with John and Danny, but Peter, your team, and CCI. It's been a really good piece of work. So in the event there isn't a hand up, what I'm going to say is thank you very much for your time. I hope we have whet your appetite to get your hands on this resource, because it's going to be invaluable in your practice. So thank you very much for taking the time, and have a great day. Thank you. Bye for now.